a lot of this information that we're going to go through today, you're going to hear again. Okay, so this is kind of your introduction to it, and then each of the pathologies that we talk about, especially come next summer in orthopedics, we're going to go a lot deeper into it. So again, I know it's long, it's still going to be a lot of information, but I think it'll be a little bit more important to you guys as we move forward in the program. Sound good? Okay, good energy this morning. All right, table of contents, we're going to talk about, we have 4 chapters today, so skeletal disorders, joint and soft tissue disorders. You guys good back there?
Sorry, my recording from last week was going. I thought I was recording you. I was like, what does that sound?
All right, so we're going to go a little out of order for the chapters, but it makes more sense grouping the content together. So I put skeletal disorders and joint and soft tissues disorders together, and then oncology and musculoskeletal neoplasms together. Okay, so chapters 9, 11, 5, and 10. Okay, so we are going to start with a little bit of review first, okay, just to refresh on some of that information from last week. So I want you guys to partner up, just take maybe 6 to 8 minutes, go through your bacterial classifications, periods of infection, and your modes of transmission. Just a few really good. All right, we're going to start with chapter 9 first. Okay, this is going to be your skeletal disorders. So like I said, this is probably going to be the most relevant, most important section to you because we're mostly dealing with the musculoskeletal body regions. So they're your musculoskeletal system. And that as PTs or PTAs, that's where most of our expertise is truly going to lie. Okay, so when we talk about the structure of the body and your movement, this is all things that is created from your musculoskeletal system. So that's going to include your things like your bones, your ligaments, your tendons, muscles, etc. Okay, so all of these things are going to work together in order to produce movement. So just a little reminder on the actual cells in the bones first. So we know that your bones create the structure for your body, but they also do a lot of other things as well. Okay, so bones are also going to produce blood cells. They're going to protect the soft tissue. They're going to create body motion, and they're going to store fats and minerals as well. Okay, and then of course we have blood that circulates through those vascular channels in the bones. So we have 3 different types of cells in the bones. Okay, so you have your osteoblasts, your osteoclasts, and your osteocytes. So your osteoblasts, those are going to be the building cells. So they're going to be more responsible for the building of the bone matrix. And then your osteoclasts are responsible for bone resorption and removing mineral content and organic material. Okay, and then your osteocytes are the mature bone cells. Okay, these are actively involved in actually maintaining the bone matrix. Okay, next we have your cartilage. So this is going to provide support, it's going to cushion and protect the bones and help to prevent them from rubbing against each other. Okay, so again we have 3 major types of cartilage. You have elastic cartilage, hyaline cartilage, and fibrocartilage. Elastic cartilage is going to be more present in your outer ears and the epiglottis. Okay? Versus hyaline, that's what is actually covering the articulating surfaces of the bones. Okay? And then your fibrocartilage, this is going to be more things like your pubic symphysis, the intervertebral discs, the menisci, TMJ. So that is more a mixture of white fibrous tissue and cartilaginous tissue. Okay, so we're going to start first with posture. Okay, so our big curves of the spine are kyphosis, lordosis, and then we're also going to talk about scoliosis. Okay, any of these can range from very mild to very severe. So starting first with kyphosis, this is the common type of curvature that you're going to see in the thoracic spine. Having just a slight kyphosis is normal, okay? But then it can also become severe or more pathologic. So if there is an excess in the kyphosis, this is going to be more that humped curvature of the thoracic spine. So it can also be called humpback or hunchback. This is going to be very common in postmenopausal women, okay? Especially those who have osteoporosis. There are 5 different types of kyphosis. So you have postural kyphosis, Scheuermann's, a gibbous deformity, congenital, and nutritional. Postural is going to be the most common type of deformity that you'll see, and this is what you guys will treat the most of. Okay? So this can be corrected with postural training, with strengthening of the back muscles, and postural reeducation. If osteoporosis is involved in this, when that occurs, you're going to get an anterior compression of a compression of the anterior portion of the thoracic vertebrae. So that's going to end up in a wedge-shaped vertebrae, leading to this excessive kyphosis. Okay. When that happens, they're going to get an excess forward bending at the thoracic spine, and that will lead to a Dowager's hump. For Scheuermann's disease, okay, this is going to be more a structural kyphosis, so not as related to posture as we just discussed. You're typically going to see this in adolescence, and it occurs when the front of the vertebrae don't grow as quickly as the back of the vertebrae. Okay, so again, you're still getting that wedge shape, but it's occurring during the growth period during adolescence. Okay, but you're still going to end up with an excessive kyphosis as a result. Okay. Gibbous deformity. So again, this is going to be more a structural kyphosis. It's going to be a little bit more angular as compared to postural kyphosis. And this is going to occur secondarily to a tuberculosis infection. So that's your inciting activity. Yeah.
Back to Scheuermann's with adolescents, it can cause it for long term, but can it be corrected with exercise if you get it when they're adolescents?
They could use bracing, more likely. They're more likely to put them in a brace in order to try to allow the anterior aspect of the vertebrae to catch up in size, but they're likely going to have more lifelong issues.
And if you see an adolescent with this, it's structural, it's not postural?
Correct.
Always?
Yes.
Oh, man.
Could be reversible in teenagers.
So that's what she was just asking. So if you were to catch it early enough and put them in a brace and allow the anterior aspect of the vertebrae to catch up in size, it could be, but they're likely going to have resultant effects long term.
And they wear it 24/7?
It would depend on the severity of the situation. Okay, we also have nutritional. So this is going to again result from more childhood nutritional deficiencies. Okay, typically a vitamin D deficiency. So here the bone is going to soften and again result in more of that curvature due to the child's weight on the spine. Okay, so again, just soft bones, likely due to a vitamin D deficiency. Okay, so like we were just discussing, you're likely going to see this as a result of degenerative disease. So over time, as somebody ages and arthritis is present, this can also cause that kyphosis, osteoporosis, developmental problems, or trauma as well. Okay, when it is age-related, you're going to see a lot of compression fractures with this as well. Okay, so that the pressure of the body weight with the position of the kyphosis is going to result in compression and cracking of the vertebrae. Okay, so a lot of compression fractures here as well. There will also be a thinning of the vertebrae, so just over time, the vertebrae is naturally going to thin. The discs are going to degenerate, so you don't have as much support and cushion between the vertebrae as well. And then, of course, if there's any other types of pathology going on simultaneously, so things like cancer or, Ehlers-Danlos, other, comorbidities will also lead to degeneration or kyphosis of the spine as well. Okay, So in terms of the clinical presentation, they're going to present with an upper spinal area that is curved forward, okay, so it's gonna look like a hump in the upper thoracic spine. They will likely have a lot of back pain, difficulty with more endurance type activities, so prolonged standing. Oftentimes you'll hear patients complain of not being able to do the dishes. So something more functional like that where you can kind of put these things together. Diagnosis here is going to be made based off of physical exam most typically. They'll likely do x-rays as well to support that, especially if they're concerned for other pathology. Make sure there's no fractures or compression fractures, anything else going on there. And then for treatment, of course, that's going to depend on the root cause of what is actually going on, okay? So, but more than likely, they're going to have some physical therapy, they'll likely be medicated in some way. Depending on the situation, they may need bracing, they may need surgery. It's just going to depend on what is actually causing it. If it is a structural kyphosis, physical therapy will not be able to change that. Okay, you can't change something that is structurally wrong, but you could prevent it from getting worse. So that would be your main goal if you were to get a patient that has a structural kyphosis. Okay, next we have lordosis. So this is going to be something that you typically see. It is normal in the cervical spine and in the lumbar spine. So that's your normal type of curve in those areas. Okay, but it can also become excessive. Okay, so again, this is going to be more an anterior curvature in either the cervical or lumbar areas. Again, you can have a lot of different reasons behind this type of posturing, but usually it's as a result of some type of compensatory measure. Okay, so whether that's compensating for your body weight, pregnancy, you'll see a lot of it in pregnancy with the redistribution of weight, or obesity where the belly is falling more forward and the back is having to compensate for that. Other things like if you have discitis, for example, okay, if you're having pain in your spine somewhere, changing your posture to accommodate for that pain, trying to offload it, trying to make yourself feel better. Osteoporosis, spondylolisthesis. Do you guys know what spondylolisthesis is? Of the vertebrae. Okay, so it's slipping, an anterior slippage of one vertebrae on another. Okay, so again, that's a chicken and egg situation, kind of what comes first, but that's something that you'll also see in relation to an excess lordosis. Again, this is going to be something that you typically just see through physical exam. Okay, x-rays if needed, but that's going to be less common for this. With this, you're going to have, again, that anterior curvature of the spine, and then you're going to have a protrusion. If you're talking about your low spine, for example, your lumbar spine, the abdomen will protrude forward, the buttocks will protrude backwards. Okay? You could see this and somebody be totally symptom-free. Just because they have this posture does not mean that they are in pain. Okay? But if it goes untreated, it's likely something where they're going to develop pain long-term, or when you're actually seeing them in clinic, they're probably presenting because they are in pain. So a lot of treatment for this is going to include physical therapy. It will be a lot of core and glute strengthening to try to normalize that posture. Okay, next we have scoliosis. So this is going to be a lateral curvature of the spine. This affects females more than it does males. It can occur, at any phase of life, but you typically see this in teenagers as they are growing. Okay. You have a couple different types. So idiopathic scoliosis is what you will see the most of. Okay. This is 10 times more likely to progress. Okay, it is the most common form. So during adolescence, you're going to have growth at different rates. Okay, so you can have rapid growth where you have now a misproportion between the hips and the legs. Things become misaligned, and that's going to result in your scoliosis. Okay. a lot of it is unknown in origin, so they do believe there is a genetic link to this. Okay, in terms of your actual clinical presentation, they're going to present with back pain. Okay, they might have rib or shoulder pain as well, and you will see an actual hump on one side of the spine. Okay, so especially when they bend forward. We'll do that at a later point, but when they bend forward, you'll be able to see a hump over top of the rib or the shoulder on one side of the spine. Okay, if you look at them straight on, their shoulders might not be aligned. Okay, but big takeaway from this is lateral curvature of the spine. Okay, so this could be structural or it could be functional. So structural, where that lateral curve is actually fixed. Okay, so again, in terms of physical therapy, when it's structural, we're not gonna be able to do anything for this. Okay, this is something that is going to require bracing, and dependent on the actual angle of the scoliosis, they may require surgery. Okay, versus functional, this is going to be more a result from compensation. So this is something where we could intervene and try to help them. So if they have any type of muscle imbalances that's resulting in this scoliosis, then we could intervene there and help them with that. The biggest one that you'll see this from is a leg length discrepancy. So if you have one leg that's shorter than the other or longer than the other, then that's going to kind of move up the chain and result in a functional scoliosis at the spine. Okay, so here is an example of a brace. So again, your diagnosis, this is mostly going to be made on physical exam. They'll likely do x-rays in order to determine how severe the scoliosis is. And then for your treatment, you're going to have a lot of different types of braces with different requirements for how long you wear them, dependent on where the scoliosis is, how severe it is, the age of the patient. A lot goes into that type of decision. But that would be made by the physician and not us. We just have to help reinforce those things. Okay, so typically you are going to have a poor prognosis if the angle of scoliosis is greater than 20 degrees. Okay, so again, this is something that you would see on the x-ray. So not something you guys are actually measuring, but information that you would get. So typically between 20 and 30 degrees is when an individual would be braced. Okay, so they would try to use that to prevent progression of the scoliosis. Versus if the curve was greater than 30 degrees, that's when they're more likely to intervene surgically. Okay, so those are your three big postures. Okay, so next we're gonna dive more into metabolic related bone diseases. Okay, so we're gonna start first with osteomalacia and rickets. Okay, so osteomalacia, this is going to be softening of the bone due to a loss of calcium. Okay, this is going to be more your adult form of rickets. So this can also be associated with severe renal disease. Okay, it's also called renal rickets, where the patient is actually in chronic renal failure. Okay, if this is occurring in young children or infants, that is when it is classified as rickets. Okay, and with that, there is a vitamin D deficiency, and the bone is not able to calcify or harden like normal. This can occur in breastfed infants who are not getting a vitamin D supplement, or in infants who are fed with a formula that has non-fortified milk. Okay, and then on the other end of the spectrum, if we're talking about elderly individuals, so elderly individuals who are not getting enough calcium or vitamin D as well. Okay, so any deficiency in these vitamins are going to cause the bones to soften and to weaken. Okay, And then if you see in this picture, because of that softening and that weakening, you're going to get structural deformities of the bone. So when you have this bow leg posture or knock knees, that can all result from this bone softening. Okay. You, in little ones, you're typically gonna start to see these symptoms between 6 months and 3 years old. Okay, usually these children are gonna have some type of stunted growth, and they're gonna start to exhibit symptoms of muscle weakness, and then it might progress from there and become much more severe, where they're actually having convulsions, or more hypocalcemic symptoms. For the skull is typically going to be enlarged and softened, okay? They might have delayed closure of their fontanelles as well. Okay? In older adults, once it becomes osteomalacia, this could be pretty asymptomatic until their bones start to fracture because of the weakness. Okay? At that point, they might have bone pain, they might have tenderness. Again, fractures might be present as the disease progresses. And that, I mean, that's the big thing there. And then they might have, as a result, further muscle weakness, and then it all just kind of feeds into each other. Okay? We also have osteoporosis. So this is gonna be more a decrease in the actual bone mass, okay? And an increase in the porosity of the bone. This is gonna be seen more in older women, typically starting in middle age, okay, especially postmenopausal women. So, for all you ladies out there, your peak bone mass occurs in your mid-20s, okay? And then it is all downhill from there. Super fun. Okay, so it's gonna plateau for about 10 years, so between, 2025 to 3035, it's gonna plateau, and then you're going to start to decrease. So initially, the rate of bone loss is 0.3 to 0.5% per year. And then once you hit menopause, that accelerates to 3 to 5% per year. Okay, so you can see that's a pretty high value.
Can you
Okay,
say that percentage again?
so initially 0.3 to 0.5%, and then once you hit menopause, it is 3 to 5%.
I just wanna say also, it's good to get a bone scan, and doctors don't necessarily say as early as we probably could.
Yeah.
And I already scanned mine, and I already have osteopenia, so
Mhm.
here we go.
Yeah.
Starting.
We had to do it, I was an exercise science major, and they made all of us do it as like a learning opportunity. And when I was freaking like 18, I already had osteopenia. Like, that's scary.
Like, I think maybe we don't absorb the calcium.
Yeah.
My doctor's not that concerned, like, she's not like, hey, take calcium, not enough, really.
And that's the big thing, like, the deep pathology with this is not really well understood, but they do know that there's some type of imbalance between the bone reabsorption and the bone formation. So there is actually a lot of debate as to how much calcium you can absorb. I can't remember the exact year now off the top of my head, but I want to say between 20 and 25, you almost stop absorbing the calcium as well. So, yep.
Just-
Get it in
just-
while you're young.
Just a comment as well, and good news is, an example is my mom,
Mhm.
70 years old, detected osteoporosis,
Mhm.
and she changed diet, activities, and a lot of walking, carefully, but now she's 80, and her levels of bone cell reabsorption is better.
That's
And it's
amazing.
coming back, then something good.
That's really
But it's nothing like it comes down, she
Yeah.
comes back. It's
A
coming
lot
back.
of it is weight-bearing activities.
Yes.
Okay, so making sure that you educate, well, do it for yourself too, but also educating your patients on the importance of that. Because they are told a lot, like you need to do safe activities like riding a bike or swimming, and those things are not going to help their bones. Okay, so you have to do strength training, you have to, lift weights and do weight-bearing activities in order to help this as well.
I used to teach at the Pilates bone building class. It was all
That's
towards
cool.
bone building,
Yeah.
yeah, all weekend, lots of all fours,
Mhm.
lots of stuff with fans, and
Yeah.
it's just, yeah.
That's great. So yeah, that's the biggest takeaway for you guys.
Clean your floors on these ones,
Okay, so Jacqueline already mentioned the DEXA scan, so we have a little bit of an image right here. In terms of diagnosis, this is going to be made by physical exam, x-ray, CT scan, and then a DEXA scan. So exactly like she said, this is, you know, I think lesser known, but the biggest aid in actually getting information on bone mineral density. So for the physical exam, if somebody's coming in, that is a little bit more elderly, they're having more nondescript pain, you always have to keep the possibility of osteoporosis and fracture in the back of your head. So doing these images, is gonna be really important to make sure that there is no fracture present, or if there is, that it is then managed appropriately. Okay, early detection with these types of testing is gonna be very important in terms of prevention, so preventing fractures, preventing falls. Like we said, regular exercise, calcium intake, and then any type of, you know, hormonal balance things. If hormones are out of balance, that's also going to affect this as well. Okay, next we have osteitis deformans. So this is going to be a chronic metabolic disease that is characterized by an overgrowth of new bone, okay? That overgrowth occurs more rapidly than the breakdown of old bone, okay? So all this is going to affect bone formation. The new bone is going to be thicker and it's going to be weaker, okay? So it has a greater potential for fracture. Again, your exact cause here is not known, but they do think that it occurs secondary to a virus. Okay? It does have a mosaic-like pattern on x-ray. So once you get an x-ray, it is pretty easy to diagnose. For these individuals, they typically are able to go a long time without having any actual symptoms. And when they are symptom-free, that's when this kind of bone abnormal destruction and remodeling are occurring, okay? But eventually, that's going to lead to pain, to stiffness, and bony abnormalities, okay? So if this is just mild, they don't have to do anything, it's just something where you would monitor the situation, and just be cautious moving forward. But then if the bony deformities become more severe, that's when surgery would be indicated. Okay, I would say this isn't something that you guys will see a lot of, just more something to be aware of. Okay, we also have osteomyelitis. So this is going to be either an acute or a chronic inflammation of the bone and adjacent narrow cavity due to an infection. Okay, so this could occur through a wound, through a nearby infection, or through skin or throat infections, okay? Most commonly, this is going to occur from staph. Okay, so especially in children and adolescents, usually from staph infection of the throat. Okay, so this is going to affect the long bones. It could result in the limbs developing shorter than normal, okay, because it's going to affect the growth plates. Okay, in terms of the actual clinical presentation, these individuals would present with chills, fever, malaise, tenderness, and they might have bacteremia as well. They're gonna have pain with movement, especially of those limbs, okay? They might have swelling. For the actual diagnosis, they're usually gonna be tender to palpate, they're gonna have bone pain on that physical exam. They're going to have elevated white blood cells in their blood test. And then the actual diagnosis would be confirmed with an erythrocyte sedimentation rate, x-rays, MRI, or a CT scan. For for your treatment, this is going to require aggressive antibiotics. And then depending on the situation, they may also require an actual surgical bone debridement. All right, next we have skeletal tuberculosis. Okay, this is gonna be a very uncommon form of TB. Okay, typically is going to involve the spine. So this usually occurs insidiously and usually about 2 to 3 years after some type of primary infection. Okay, it is gonna be spread through the body's bloodstream, and it's gonna go to the long bones and the vertebrae. Okay, initial signs and symptoms, again, usually this is mostly going to affect the spine. Okay, so they're gonna have pain in the spine, they might have stiffness, and then they're also going to have systemic signs as well. Okay, so chills, fever, fatigue, weight loss, etc. So it can present in a lot of different ways. In terms of diagnosis, you're gonna have X-ray, CT, or MRI, and then it's going to be confirmed with a smear test and a culture in order to actually look at the microorganisms. Okay, for treatment, they're gonna require medications, they may require a surgical debridement, and they may also need chemo for spinal tuberculosis. Okay, in terms of prognosis, one more important thing to mention here is that this can also cause paralysis when it's really severe. If that paralysis exists for more than 6 months, then these individuals are not likely to improve. Okay, so this can be really severe. All right, next we have bone fractures. So you guys are gonna see a lot of these, so make sure you know these different types of fractures. Okay, so of course a fracture is going to be defined as any type of discontinuity of a bone. Okay, first we have stress fractures. So this is going to be an incomplete fracture. So the bone is not actually broken into 2 different pieces. It's all still together. It's just more like a hairline. Okay, stress fractures typically occur due to repeated abnormal stressors. Okay. A lot of things like running, for example. You'll see a lot of stress fractures in runners. Okay. You also have pathologic fractures, where this is occurring secondary to some other type of pathology. Okay. Cancer, reduced bone density, things like that. Okay. And then we have insufficiency fractures. So here, the actual bone is going to have structural change due to poor calcium metabolism, osteopenia, or osteoporosis. Okay, so the bone is weakened with decreased mineralization. We have 4 big types of fractures. Okay, so we have open fractures, closed fractures, complete fractures, and incomplete fractures. In an open fracture, the bone has protruded through the skin. Okay, you can see the bone. These may also be called compound fractures. Okay, since the bone has protruded through the skin, these are going to be at high risk for infection. Closed fractures. Okay, so here the bone has not come through the skin. Everything is occurring internally. Okay, so bone is not exposed to outside environment. It's not quite as severe. Complete fractures are fractures that go through the entire bone. Okay, so that means the parts of the bones are completely separated. Okay, so you have at least 2 pieces. Okay, those have subcategories, so they can be called transverse, oblique, spiral, longitudinal, or convoluted fractures. And we're gonna go over all of those in the next slide. Okay, we also have incomplete fractures. So you have a fracture of the bone here, but it is not in 2 pieces. Okay, here here are some other terms that you might hear when it comes to bone fractures. Okay, so you have a green stick fracture, which is basically a partial break. A displaced fracture, where the bone fragments have moved out of position. Okay, so they're not held together. Comminuted means that there's more than two fragments. Compression, the two bones have literally compressed together. Okay, so they're smashing into each other. Okay, you'll see that a lot in the spine. And then impacted, the bone is forced over the other end of the bone. Okay, so here are again a breakdown of your different types of your complete fractures. So starting first with your avulsion fracture. So here you have a small bone fragment that has separated from another bone. So this is going to occur at an attachment for a ligament or a tendon. Okay, so a common one that you'll see is an avulsion of the hamstring. Okay, where the hamstring tendon attaches to the bone. If that hamstring contracts forcefully and pulls away, you're going to get a bone fragment that comes with it. Okay. A longitudinal fracture, this is going to run the entire length of a bone. Transverse fracture runs at right angles to the bone's axis. Oblique fracture, there's that transverse pattern, so it literally just runs at an oblique angle. The spiral fracture, just like it says, it's almost like the bone has been twisted. So the fracture line looks like a spiral. Okay? And then a stellate fracture. So this is going to be more a star-like pattern. Okay? So there's going to be a central point of injury, and then the fractures are going to kind of radiate out from that central point. Okay? In terms of diagnosis, it's going to be different depending on the type of fracture present. So if this is more traumatic versus insidious, for example, okay? If it is a stress fracture, there might be minimal pain versus, oh, I was just in a car accident and my bone is sticking out from my leg, that's gonna be a little bit more painful, okay? So in terms of symptom presentation, they're likely gonna have pain, inflammation, there might be discoloration. If the skin is punctured, there's gonna be bleeding, etc. So it's just gonna depend on the severity of the actual fracture. For diagnosis, this can be made through physical exam, x-ray, CT, MRI. For stress fractures, that might not always be picked up on imaging, especially if it's an early on stress fracture. So getting a bone scan, a DEXA scan, can sometimes pick up on those more quickly as well. In terms of treatment, again, this is going to depend on the severity of the fracture, okay? If it was a traumatic fracture, initial steps need to be stop the bleeding, stabilize the fracture, okay? Splinting, immobilization, and then reduction of the fracture if it is displaced. Okay, so you guys don't need to, I'm not gonna go there, but someone else needs to reduce the fracture as quickly as possible, okay? And then, depending again on the situation, they might be splinted, they might be cast, it could be a hard cast, it could be a soft cast. They might need surgery. This could be an open reduction, internal fixation is the most common thing that you're gonna see. You may also see external fixation, okay? External fixation is what is in these images up on the board, okay? As you can see, they're really intense. Okay, and they are very highly susceptible to infection. Okay, so just something to kind of keep in the back of your head. It's very important to keep these clean and keep them safe if you're working with a patient that has them. Okay, and then here's just a diagram for the process of fracture repair and what that actually looks like in terms of your stages. Okay, so your blood clot forms. The blood clot is then invaded by the fibroblast. It works to form a callus, and then calcium is deposited into that callus, and then the fracture is repaired. Okay, so make sure you just know those steps from a general standpoint. Okay, traction is something that you might also see with this as well. okay? Not like the mechanical traction that you guys are gonna use in modalities, okay? This is specific for fractures, okay? So this basically is used in order to hold a fracture in place. It can also help to reduce muscle spasms. It lets everything else relax around it, and then helps to maintain a reduced amount of tissue damage as well. Okay, so this can be used for a little bit longer term when large muscle groups are involved. They basically can put a pin through the bone and then attach a pulley, weight and rope system around the entirety of the fracture to maintain it in place where they need it to be in order to reduce it. This one you will see for cervical fractures. Again, it's just helping to stabilize that fracture, keep it in place so it does not go through further damage while it is healing. This is another type of cervical traction that would be done if it's somebody, in supine for long periods of time. There's also skin traction as well, for smaller regions, smaller areas when the skin is more involved. Okay, moving on from bones, another thing that you guys are going to see a lot of is herniated intervertebral discs. Okay, so with normal aging, you're going to have a progressive decline of the quality of the discs. Okay, both of the nucleus and the annulus. With that, decrease in quality as well as increase in stress over time, it is very common to rupture the annulus fibrosis. Okay, you might get a herniation of that nucleus pulposus. It could be very small, or it could go all the way into the spinal canal. This mostly occurs in adults less than 45 years old, okay? People who are doing more physical stress in life. And like I said, we're gonna dive a lot further, more deeply into this material come orthopedics next year. So at least for now, make sure you understand the basic structure of the disc, that you have the two different components, the nucleus pulposus, the annulus fibrosus, and just some of your general symptoms from now, and then we'll build upon that as we move forward. Okay, so big causes here again is going to be trauma related to physical stress. Okay, this could be acute, it could be repetitive stress over time. A lot of individuals will have degenerative disc disease, and then of course any type of faulty posture or poor mechanics. Okay, especially when it comes to lifting. Poor mechanics when it comes to lifting can really get you in trouble here. Okay, so again, with any of these things, you could get a tear, you could get a rupture of the annulus fibrosis. This could cause irritation of the nerve root. So if any of that gelatinous substance is hitting the nerve root or compressing the nerve root, that's when you're gonna get the symptoms going down your leg. Okay, so when people talk about having a herniated disc, talk about sciatica, usually that's what's happening. Okay. In terms of the clinical presentation, okay, they may or may not present with low back pain. The big signs here are going to be the radiating symptoms that go down the leg. Okay, so it says into the buttocks, legs, and feet. In order to truly classify as this, it has to go below the knee. Okay, so radicular pain going below the knee. These are going to be diagnosed through physical exam as well as an MRI, most commonly. In that MRI, they are looking for the nerve root compression. Okay, so they should be able to see the nerve root being compressed by some other material in that imaging. For treatment, typically they're going to be sent to physical therapy first and trial conservative management before doing anything else. So a lot of this will include core stabilization and then addressing any faulty postures, poor lifting mechanics, all of those things, trying to calm down the nerves. They might be put on a dose pack, so a steroid pack for X amount of days just to try to get the nerve to calm down. And then after failing conservative management, typically, if they continue to have symptoms, that's when they would go in and do a surgery. Okay, so they could do a discectomy where they take out part of that disc material. They could do a laminectomy where they open up some of the areas surrounding that nerve root so it has more space. Okay, we're gonna take a little bit of a break, and I want you guys to partner up. I lost internet up here. I don't know if you guys have it, but I have connected the computers to my hotspot, so no promises that we're gonna be able to advance through this entire lecture, but we'll do our best. All right, so we are going to move on to chapter 11. So again, this is joint and soft tissue disorders. So again, a lot of things that are gonna be really relevant to you guys in our actual profession. Okay, so starting first with rheumatoid arthritis, this is also called RA. Okay, this is going to be a systemic autoimmune disorder. So it's going to affect the joints and the connective tissue through the body. This can really affect people systemically. Okay, so they're going to present like they have a chronic illness. Okay, it can not only affect these joints that we talk about from a musculoskeletal perspective, but also the blood vessels, the heart, the lungs, etc. So again, this can be really debilitating for people. You'll see this in more young and middle-aged women, most specifically. It typically is going to start, you'll see it mostly in the smaller joints of the hands and the feet, and then progress from there. So there are 3 phases to its progression, okay? Phase 1 is going to be the initiation phase. This is going to be very non-specific, but there is going to be inflammation. Phase 2 is called the amplification phase. This is going to be caused by the T-cell activation. And then phase 3 is the chronic inflammatory phase. Okay, so this is where it's now becoming a chronic issue. So again, similar to some of the other things we've talked about today, there's not an exact known cause. But they do know that it's going to be related in some way to abnormal antibodies that either attack or attach to the body's cells and tissues. They do believe that it is hereditary in nature, okay, and it can also be triggered by viral infections. Okay, in terms of clinical presentation, like we saw in the last photos, there's typically going to be a very visible deformity in the hands or in the feet, in your small joints, so specifically your MCP or your MTP joints. They're going to be very nodule in nature, so it's going to look like somebody has these little nodules all over their hands. You might have other signs of inflammation, so their skin, they might feel warm, it might be like really inflamed, it might be red, so all of your typical signs of inflammation as well. And then like we said, so not only from a musculoskeletal standpoint, it can also affect other organs of the body as well. So they are going to have more of those systemic symptoms. So feelings of fatigue, pain, stiffness, swelling, weight loss, all those types of things. In terms of time of day, any type of arthritic condition, this included, they are going to be most stiff first thing in the morning, and then it will get better as they progress through the day. For the actual diagnosis, this would have to be diagnosed through blood testing. Okay, so they're going to look for a rheumatoid factor, and then in addition, they would have a physical exam, they would look at family history, etc., in order to make a full diagnosis. For treatment, again, this is not something that you are going to reverse with physical therapy. You are just going to manage the symptoms. So trying to maintain as much joint range of motion as possible. That's really going to be the first priority. Maintaining your joint range, trying to minimize the stiffness, minimize the swelling, just help them to feel a little bit better. Okay, so again, managing symptoms, not trying to reverse what is already present. Okay, osteoarthritis, we've already talked about this a bit today, so a little bit more here. Again, this is gonna be more your wear and tear type arthritis. It's gonna be a natural part of your aging process. This is actually the leading cause of disability in the United States. Your primary change with this is going to be the degeneration of the articular cartilage. Okay, remember how we talked about the articular cartilage protecting the ends of the bones? Okay, so you don't get that bone on bone. But once that has degenerated, then you're just getting that rubbing together of two different bones. And that's gonna cause a lot of issues. Okay. Again, in general, this has an unknown origin. Okay, but they do know that it worsens with age. It's from that wear and tear. It's going to degenerate over time. Okay, when you do get that bone-on-bone mechanism, this does cause bone spurs as well. Those bone spurs can also be a source of pain, of joint limitation, and etc. So I do have one slide comparing osteoarthritis and rheumatoid arthritis. Again, you don't want to get these things confused because they're two completely different pathologies. So remember, your rheumatoid arthritis, this is going to be autoimmune in nature. Okay, so for rheumatoid, since it is a more systemic condition, this is going to affect joints bilaterally, so it's going to occur on both sides of the body. Especially the morning pain, morning stiffness, you're going to have symptoms for greater than an hour. Versus osteoarthritis, usually your symptoms here are going to be less than an hour in the morning, and things will loosen up and ease off as they start moving through the day. Osteoarthritis is only going to occur on one side of the body for a specific joint, okay? You could have osteoarthritis in both knees, so I'm not saying that it can't be bilateral, but you can also just have it on one side, okay? Having it on one side is more common than something like rheumatoid arthritis, okay? Again, osteoarthritis, this is going to be isolated. This is going to be something that occurs at one joint. You have pathology in one area versus rheumatoid is going to be systemic in nature, okay? This is also going to be much more severe than osteoarthritis. For your diagnosis, of course, physical exam, they're likely going to do x-rays as well, and a thorough patient history. For treatment, so again, just like we talked about earlier, the first prescription is going to be non-weight bearing exercise, okay? So that's not necessarily going to help the quality of bone, so something to keep in mind. Rest, eat, anti-inflammatories, steroids, all of those things are the first line of treatment. From our perspective, that's probably not going to do anything, okay? So we need to make sure that we are normalizing joint range of motion. Usually that's primary issue number one, okay? And then strength, okay? That's what these people really need. And you have to be comfortable and confident educating your patients that that is what they need. Oftentimes they're not going to want to do those things. So you really have to sell it and help them to understand how important it is. Most of the time, especially when it comes to knees, you are going to see more knee replacements than anything else. Once somebody gets to this point, they are convinced, the surgeons are convinced that surgery is the only option. Okay, so you'll get a lot of them post-operatively. But a lot of times, as physical therapists, we are capable of prolonging that. Okay, if you have a patient that actually listens to you, you do what you're supposed to do, a lot of times we can prevent the surgery as well. Okay? That's a little bit of a soapbox. But just know, normalize range of motion, strengthen the muscles surrounding the joint involved, and that can do a lot of good as well. Oh, we're not moving. Oh, gosh. Are you guys able to move?
Mm-hmm.
All right, next we have, hang on, it went too far. All right, we have ankylosing spondylitis. Maybe it'll catch up at some point. Ankylosing spondylitis, have you guys heard that before?
Mm-hmm.
That was a lot of mumbles. Are there any yeses?
Yes.
Okay, got a couple. So what is it?
Don't know, I heard it.
Okay, so this is actually going to be an inflammatory condition that causes a really severe inflammation most specifically of the spine and of the pelvis, okay? So this is going to result in the actual fusion of the spine and the pelvis, okay? Oh, hang on.
Oh,
No, okay. Oh, there it is. Okay, so, like we said, inflammation and fusion of the spine and the pelvis. So this can also cause fusion of the rib cage, which can restrict the ability of somebody to breathe. So reducing your lung capacity, reducing your lung function. Typically, you're gonna see this in younger individuals, usually starting about age 20. So 20 to 40 is your big window where this becomes more present, okay? They do think that there is a genetic link to this condition, that it is believed to involve immune-mediated inflammation, okay? So the actual thing involved here is called human leukocyte antigen, okay? So again, the presence of that indicates this condition, and that's why they believe that it is genetically linked. So basically, your new bone forms, and the body attempts to heal itself, which results in that fusion of the bones, okay? So this is typically going to start at the SI joint, okay? Not sure if your book says that, so make sure you write it down. But typically, that is the first joint involved, and then it progresses up the spine, okay? So they're usually gonna have either very pinpoint SI joint pain or generalized low back pain. And symptom-wise, it's going to be worse at night, better during the day, okay? They will typically be in the most pain when they first wake up, and then their symptoms actually improve with activity, okay? So as they start getting moving for the day, if they go on a run, if they go on a bike ride, that's when they're gonna feel the best. Okay, so that's a pretty good indicator of something like this going on. Okay, so over time, the fusion is going to progress. So you will see a progressive loss of mobility, loss of range of motion. Okay, so for the diagnosis, in order to diagnose it, they are going to look for that human leukocyte antigen. It is called HLA-B27. Okay, so that's what they would get from the blood work, and then they're also gonna do imaging as well, okay? On the imaging, an X-ray is perfectly sufficient. As the condition has progressed, they are going to get what is called a bamboo spine, okay? So it looks like this, where you can actually see the fusion of the vertebrae from the X-ray, okay? So if you look at a normal one that's not color-coded like this, it literally looks like a stick of bamboo, okay? In terms of treatment, NSAIDs, corticosteroids, a lot of medications, but from our perspective for physical therapy, it's going to be more creating a movement-based plan, okay? So helping to maintain as much range of motion as you can. Again, this is progressive. They are going to lose range of motion one way or another over time. So your job is just to give them the tools, give them the education that they need in order to maintain as much range of motion as they can, okay? So with that, the prognosis it varies a lot, okay? Okay, we also have osteonecrosis, okay? So here, the blood supply, the cartilaginous ends of bones are going to experience necrosis, okay, or degeneration. So this is called osteonecrosis. You'll also see it called AVN or avascular necrosis. So those terms can be used synonymously. This is the biggest place that you guys will see this is the femoral head. So avascular necrosis of the femoral head is very common, especially in younger children or adolescents. This can also occur in adults if that blood supply is interrupted for any reason, okay? If there's some type of compression, if there's trauma, that blood supply is interrupted, that will also lead to an AVN of the femoral head as well. Okay, so again, this can occur following an injury, or it can be an insidious onset with something, some causative factor that is more unknown. In adults, the most common, more unknown causes are going to be from excessive or chronic corticosteroid use, as well as excessive alcohol consumption. Okay. Typically, presentation-wise, these individuals, they're gonna start as asymptomatic first, okay? That could be for weeks, it could be for months, and then they're going to gradually progress in terms of their symptoms and their level of disability. So as the AVN gets worse, as the degeneration of the femoral head worsens, their symptoms will increase as well. So typically, they're gonna have some pain, some achiness in the involved joint, and then especially since this occurs most often at the femoral head, visible signs are going to start with a limp. So usually that's the first thing that you guys will see as providers, is somebody walking in with a limp, okay? Again, a lot of times this is going to occur in children. You'll probably see it more in children than you will adults. And a lot of times they can't articulate well what is going on. So those visual cues are very important. So whenever you have a patient, every time they come in the door, you should be watching how they walk in. Okay, because that's a big sign for this. Okay, so with that, you have a limp, you're gonna have groin pain. Okay, that's gonna be another very common symptom. It could radiate down further into the thigh or back into the buttock as well. Range of motion is going to be limited. So when you go and assess passively, usually hip flexion or your rotational motions are going to be limited. For diagnosis, first it's gonna start with a history and physical exam, but you're gonna need imaging to fully diagnose this. So X-ray, MRI, they might need a CT scan or a biopsy as well to figure out what's actually going on. Okay. In terms of treatment, it's going to depend on the causative factors, of course. Is there a true disruption to the blood supply that needs to be surgically intervened upon? In terms of physical therapy, again, your job is, whatever the cause is, to restore or maintain range of motion, okay? Range of motion, strengthen the surrounding area, okay? But a lot of times, that's probably gonna be ineffective, if we're being honest, and they're gonna result in surgical intervention, most likely hip replacement, okay? Even for these young kids. For the young kids, they will try to prolong that as long as possible. But that's usually the surgery they're gonna end up with. Okay. All right, completely different direction here. We have gout next. So this is going to occur due to an elevated level of uric acid, okay, in the blood and the body fluids. So with that, there's going to be sodium urate crystals that end up getting deposited in the joints or surrounding tissues. Okay. These levels can be elevated due to several different reasons, okay? Decreased renal excretion is the most common cause, okay? But there could also be an increased production of urate or increased purine intake, okay? The most common place that you're going to see this is the first metatarsal, okay, so the big toe. Usually there's gonna be a lot of pain at the big toe. Okay, it's going to be red, it's gonna be swollen, it's gonna be painful to walk. That's the biggest presentation that you guys will see, okay? There can be other signs in the kidney, okay, so they could have kidney pain, they could have kidney dysfunction or kidney stones as well. This usually occurs in attacks, okay, so there's going to be an attack. It'll last for a few days, and then it will calm down, okay? As the disease progresses, it can attack multiple joints at the same time, okay? But usually, most commonly, you're just gonna see it very isolated in the big toe, one joint at a time. It can last for about 3 weeks. Again, usually it will start as just a couple days, but then again, as the disease progresses, if it goes untreated, these attacks can last for several weeks, okay? And then these individuals will likely have several attacks per year, okay? Most typically, you're gonna see this in adult males over the age of 30, okay? So like we said, right here, this shows that the uric acid deposits go into the big toe. So I know it's not a great picture, but you can see this area right here, that's where it's red, that's where it's swollen, and you're gonna get those nodules. In terms of diagnosis, this is going to occur with an arthrocentesis. So that's basically where they go in, they take a needle and they aspirate the joint fluid, and then they can look at that fluid and see what's in it, okay? So they can also look at blood levels and look for that elevated serum urate levels. You can look at an x-ray of the affected joint as well, okay? In terms of treatment, a lot of this is going to be medication-based and diet-based, okay? In terms of diet, they need to, well, one, likely reduce their weight overall, okay? And then remove things that have that excess urate in them. So things like alcohol, beer is a big one, red wine, meat, red meats, a lot of that can end up causing this as well. Medication can be used to dissolve the tophi that is present in the joint. Okay, it can also be used to reduce the inflammation, especially long-term. But in terms of actual physical therapy, there is not much that we can do for this, okay? Since this is more an issue going on internally with uric acid levels, diet, nutrition, we can't really do much about that aside from education, okay? So if you did get somebody with this, if this is what you were actually treating, the biggest thing that you could do is just try to restore the range of motion to the great toe. Okay, but outside of that, we're not gonna be able to do much. Okay, next we have, TMJ, so temporomandibular joint. So again, this is one that we'll dive a lot deeper into next summer. So for now, just know that it's gonna be inflammation of the joint, okay? There are a lot of different factors that go into this type of pathology, okay? It could be some type of internal derangement of the joint, if your teeth don't quite sit together. Also, a lot of contribution from parafunctions. Okay, parafunctions are things like excessive gum chewing, biting your nails, any type of, little things that you do repetitively with your jaw that could feed into this. Okay, bruxism, grinding your teeth, whether that's due to stress or at nighttime, if you wear any type of mouth guard, things like that, all of that can play into TMJ, okay? In addition, a lot of this can also be due to emotional distress, okay? You'll see this with people who have a lot of other things going on in their life, okay? Emotional distress, headaches, it's also associated with headaches. So again, chicken or egg situation, what comes first? If somebody has really severe migraines, they're more likely to have TMJ dysfunction as well, okay? Let's see, this is going to affect individuals, again, typically in that 20 to 40-year-old range, okay? Let's see. In terms of your signs, so there's going to likely be clicking at the actual joint, okay? The clicking could occur with different activities, with chewing, with biting, with talking, and it's just gonna get aggravated with repetitive use. There might be a range of motion limitation, so there's several different diagnoses you can have here, and depending on the diagnosis, it's going to present differently. So you could have hypermobility at the joint, where you have excess motion, Or you could have hypomobility, where everything is going to be really tight, the surrounding muscles are gonna be tight, and the range of motion is going to be restricted. Okay? In terms of diagnosis, this is mostly gonna be made from physical exam. You might also require dental x-rays. And then I'll teach you guys a bunch of TMJ exercises next summer, so you'll know how to treat this if you do get somebody like this. Surgery is not very common here, but it could be used if they were to fail conservative management first. Okay, next we have reactive arthritis. So this is a form of arthritis that's typically preceded by some type of genitourinary or gastrointestinal infection. Okay? So this could have it could be very acute and very sudden, or it could be more episodic where you get continuous recurrence of it. A lot of cases of this will develop after a sexually transmitted infection. Okay? There is a genetic predisposition of this. So like I just said about the STI, there are two common forms of this. So one being sexually transmitted and the other being dysenteric. Okay? So this can affect several different body systems. Okay? They're going to present with more systemic symptoms. So fatigue, fever, weight loss. You could still have joint pain or inflammation. And then in terms of most common areas affected when it comes to your joints, you're gonna see the most symptoms in the lower extremities and the feet. Okay. For treatment here, again, most of this is going to be medication-based. We're not really gonna have much to do with this type of condition. And then symptoms typically resolve within about 3 to 4 months, okay? Again, if you do see somebody, you're always going to address the symptoms that they have in terms of musculoskeletal symptoms. So if they're having hip pain, if they're having knee pain, restore the range of motion, emphasize strength in those areas. Okay, next we have a bunion. Okay, this is something that you guys will see a lot of. This is also called hallux valgus. Okay, that's the official term for it. So basically valgus of the great toe. Okay, so this is going to affect the MTP joint of the first toe, of your big toe. Okay, so that toe at the MTP joint, it's going to be painful, it's going to be swollen, and it's going to have restricted range of motion. Okay, so in terms of presentation, it will almost look very similar to gout, like we just talked about. Okay, but there's not going to be that systemic component to it. This is a true isolation at the first MTP joint. Okay, so you're going to have that valgus position of it where the toes angle inward, first MTP is angled outward. Okay. In terms of your causes here, this is going to be due to excessive foot pronation. Okay, so if you have that inward falling of the foot, of the arch, your arches are collapsing. And then often poorly fitted shoes, okay? Especially females who wear high heels. When the toes are clamped together or crunched together, you're gonna see a lot of that with that population as well, okay? There is a genetic component to this as well, okay? It is mostly believed that this is inherited in some way and then facilitated by your daily postures, your daily habits, and your shoe wear. Okay, you got a question?
I do, what do you guys think? Is valgus and vargus related? Cause that carrying angle, when it was angled in.
Yeah,
the
so
distal
it's the same terminology like we talked about for the elbow as for the foot. So at the elbow, I can't make myself do it, but right here, that's gonna be valgus. So an angling in. So it's the same
Fingers
thing
out?
at the toe, yes.
Fingers out is valgus.
Versus this is gonna be more varus.
Varus.
It's not a rotation at the shoulder, it's the actual angle at the elbow.
Fingers out,
So it's all
varus.
Does that make sense?
It said something about the distal end of the bone. What bone are we talking about at the ankle?
So right here, it would be my ulna and my radius.
Are in.
This is gonna be valgus, where ulna and radius are pointed out and my humerus is pointed in.
Where's in?
So it's making an actual ankle at the elbow.
Okay.
Versus varus, my ulna and radius are going to be pointed inward and my humerus is gonna be pointed out.
Okay, thank you.
Okay, same thing at the knees, you're gonna hear it at the knees a lot. So at the knees, if you're more knock knee, that's gonna be valgus. Okay, where my femurs are adducted and internally rotated, and then my tibia and fibula are outwardly angled. Versus varus would be like that. Does that make sense?
Yeah.
So same thing at the foot, you're overpronated at your arch, but then your great toe is angled inward. Or outward, I guess technically.
The difference between bunion and gout would be the pain.
Not the pain, the systemic component. Gout is an inflammation that is manifesting at the first metatarsal due to elevated uric acid levels in the blood.
And bunion is literally the bone that's
It
increased.
is, exactly,
Hallus.
it is just occurring locally at the first metatarsal. Everybody good? Are we sure?
Mhm.
Okay.
Any memory tricks? I'll figure it out.
Okay, so, let's see. So for your bunion, a lot of people will live with this for a long time, okay, before they seek treatment. A lot of it is, they don't like the look of it, okay? A lot of it is not typically a functional deficit, it's just something where they feel a little bit more insecure about it and want it taken care of, okay? Or it's rubbing on their shoes a lot, they're having pain when they walk because of the contact with their shoes, okay? So, you may see these preoperatively, but I would say not very often. If it gets to the point where somebody wants something done about it, usually the first line is going to be surgery, okay? If you were to intervene preoperatively, a lot of it is going to be great toe strengthening, okay? And we'll dive into that later, but that would be the primary focus. Great toe range of motion, great toe strengthening is what you would do preoperatively. Postoperatively, treatment is gonna look very similar. You have to abide by your surgical precautions and whatever that surgeon says. But they will go in, they'll do a bunionectomy where they remove the bunion, they may need to realign the toe. And then afterward, again, your primary job is to restore great toe range of motion and strength. Okay?
Do you like toe spacers? Have you seen those silicone toe spacers?
Yep, so that's a really good, intervention for this population.
And then shoes just don't fit. I've seen these shoes that are like stretchy that people like,
Mhm.
that can help.
Yep. Anything with a really wide toe box. is what you should include. Okay, next we have bursitis. This is going to be inflammation of a bursa. Okay, this could occur anywhere where a bursa is present. So a bursa is gonna be a small fluid-filled sac. Its job is to reduce friction between two adjacent bones, okay? Or a tendon and a bone. Oftentimes you'll see a bursa that sits in between a bone and a tendon to reduce that friction, help it to move smoothly and protect it, okay? So for whatever reason, the bursa has become irritated. It gets irritated, it gets aggravated, painful, inflamed. So, this can again develop very acutely or more insidiously. But wherever it's occurring, they're gonna have a lot of pain. These are big pain generators, okay? So these are usually painful conditions. And then they're gonna have limitation of joint range of motion at the joint that it is near. This is mostly going to be diagnosed by physical exam. And then for treatment, they might be put on anti-inflammatories. They might be given a corticosteroid injection. They might have to drain it and rest and surgery as, you know, your last resorts here. Okay? The biggest type that you'll see often is, did we talk about this in the elbow? I was gonna say, I remember that picture. So elbow on the desk, head sitting on your hand, it's gonna irritate the elbow person. Okay, so that's a really common one. Also behind the ankle, like if somebody has Achilles tendonitis, something like that, there's one that sits, there's a bursa that sits on the back of the heel, right underneath the Achilles tendon, that very commonly gets aggravated as well. Okay. Dislocations and subluxations. So a dislocation is going to be a complete separation of the bone from its articulating bone, versus a subluxation is just going to be partial. So it might partially separate, but not fully separate. Okay. Shoulders are going to be the most common area where this occurs. So the shoulder, it could completely, the humeral head could completely disarticulate from the glenoid, versus it could just slip slightly forward, backwards, or inferiorly. Okay, these are usually pretty obvious, okay? They're gonna be very painful, someone is going to immediately know something is wrong, and then it would have to be relocated, okay? The quicker that you can reduce it, the more successful they are going to be, okay? The longer you wait to reduce a dislocation, the more the muscles and surrounding tissue are going to tense up, and it is going to be much more difficult to get the joint back in place, okay? If there is not that immediate reduction, a lot of times they're gonna have to be put under general anesthesia in order to relocate it. So, again, it just has to be done quickly. Once this becomes repetitive, like if it just happened once, okay, but once it becomes repetitive in nature, if somebody's shoulder is continuously dislocating, that's when they're gonna have to go in and surgically intervene. Usually that's gonna be a labral surgery of some sort. All right, more soft tissue in nature here. We have myositis, which is also called myopathy, okay? This is going to be a disease of the muscle fibers where they do not function properly, okay? And this is going to result in muscular weakness. This has a genetic predisposition as well, okay? And then it can be precipitated by any type of injury, infection, or autoimmune disease. But here overall, there's just gonna be a lot of swelling, pain, muscle loss, muscle weakness, and fatigue. In terms of treatment, this again is going to be mostly medication-based. And then for physical therapy, it would just be specifically addressing the muscle weakness that is present. Okay, we also have polymyalgia rheumatica. So this is, again, something where your etiology or pathophysiology is unknown, okay? They do believe that it results from a synovitis or a bursitis, okay? Symptoms here are going to include bilateral aching, okay? Mostly of the shoulder, of the shoulders or the hips, as well as the spine. So usually back, upper back, neck, that's where you're gonna get most of your pain for this. With the symptoms, they're usually going to have the most pain, the most stiffness, again, first thing in the morning, and then it is going to improve as they start getting moving and going throughout their day. Okay, so it's gonna present more arthritis in nature. Okay. They are going to feel weak, but actual muscle weakness is not a part of this condition. Okay, so that can be an important differentiating factor. Prednisone is usually the first line of treatment for this, okay? We'll talk about prednisone a lot as you guys move forward in this program, but know that prednisone in short doses is okay, but a lot of conditions require long-term utilization of it, and that's not really a good thing either. All right, polymyositis. So this is going to be a muscle disease where you have a lot of muscle inflammation that is more localized to the trunk or torso, okay? But it will result in very severe muscle weakness, okay? again, your origin here is going to be unknown, but it does occur when there is an excessive amount of white blood cells that invade the muscle tissue, okay? With that, there's going to be the production of a lot of muscle weakness, and atrophy of the actual muscles. For diagnosis, they're gonna go through patient history, patient exam. They're going to do a very thorough screening to make sure that this is not cancerous. Okay, so that's going to include blood analysis, likely biopsies, muscle biopsy to identify this condition. Okay, so treatment here is basically directed at stopping the overactivity of the immune system. The immune system is working too hard, it is on overdrive, and it doesn't need to be. So that's the goal of all of the medical interventions. So more steroids, immunosuppressives, and then for us, it would just be more helping to get them active and exercising. Make sure that we're addressing, again, any of that excess muscle weakness that they have presented with. So again, most specifically to their torso regions.
Is this, pretty rare?
Yes, I mean, I don't know what the actual incidence is of it, but it's not like, I've never seen it in clinic.
My ex-mother-in-law, I guess, passed away, had this, it was
Really?
misdiagnosed for years.
How did she present? You know?
They thought she had rheumatoid, but I mean, she was living in a small town in northern Michigan,
Mhm.
like, she didn't have that.
Yeah,
I don't know, I have to ask her husband.
yeah, that'd be interesting to.
She ended up
see.
dying of blood clots that went to her lungs, but I don't
Interesting.
know if that was because
Like
they ended up
related
having
or
a
not.
genetic clotting thing.
Mhm.
But she was in pain,
Mhm.
she was hurting, they thought it was joint, but it was all over her muscle.
That's
Finally,
so
University of Michigan diagnosed her, but like years later.
Long time. And that's scary with a lot of these different things. They can go misdiagnosed for so long because things clinically will present as other things. Like you can see how much crossover there is between the different conditions. And if you really don't sit and take the time to go through every symptom or do every test for these different things, they're very easy to misdiagnose.
I'm gonna find out, I'm gonna ask more about these.
Yeah, that would be interesting. Muscular dystrophy. This one is a really sad one. The term muscular dystrophy in itself is kind of more an umbrella term that is inclusive of a lot of different genetic disorders, okay? But all are going to be related to progressive degeneration of skeletal muscles, okay? The most common type that you will see is Duchenne muscular dystrophy. That's the most common form. And this is going to occur in young boys aged 2 to 5. Okay? And there's going to be a development of this due to mixed muscle cell hypertrophy, atrophy, and necrosis. Okay? So basically, as the muscles undergo this necrosis, then fat replaces muscle tissue. Okay? So over time, as that fat is replacing the muscle tissue, the muscles are going to weaken. Okay, you're gonna have to decrease muscle size. This is going to be an inherited disorder, okay? It is an X-linked disorder, so it is passed from mother to son, but it is only present in the sons. Okay, so females are not going to present with this. Usually, initially, they're going to be asymptomatic. Okay, so right at birth, during initial infancy, you're not going to see any signs of it. Okay, so your early infant motions are going to be intact. So rolling, sitting, standing, everything is going to progress as normally. And then it will start to present itself usually around 2 to 3 years old. Okay, so once they're standing, they're going to start exhibiting frequent falling. So that's usually the first sign. Okay, the picture that I have on the board is called Gower's maneuver, and it's basically how they end up getting vertically from the floor. So if they're on the ground, they will use their hands to climb up their legs in order to come to standing. So that's usually one of the first signs that as clinicians we can pick up on in order to know that this is occurring. Okay, so Gower sign. So these boys will usually become wheelchair bound by 9 years old. Okay? With that, they have a very poor prognosis and they're gonna have very early death. In terms of treatment, you're gonna see a lot of orthopedic devices, okay? So, braces, leg braces, standing devices, walking devices, wheelchairs, all of those types of things. And then for treatment, again, it is just helping to keep them as active and independent as possible. All right, next we have myofascial pain syndrome. So this kind of can go hand in hand with TMJ disorder, where a lot of it is going to occur secondary to grinding at night, okay? So, or if you have that irregular tooth contact, and then like I said, a lot of psychosocial factors also play into this. So if you have a lot of emotional distress, things going on at home, sleep disturbance, all of those types of things as well. But this is basically going to be, think like face pain. So pain in the muscles over top of the jaw muscles will be very painful, intense. There's going to be limitation in joint range of motion at the jaw, okay? And then you'll likely also see a deviation upon opening the mouth. So the jaw will deviate to one side because of the tightness of the muscles, okay? So again, for physical therapy, most of what we are going to do is going to be intervening at the actual TMJ. So helping to calm down those overactive muscles, teaching them exercises in order to maintain appropriate positioning of their teeth, of their tongue, and of their jaw. They may also be prescribed splints or mouth guards. Okay, that's not something that we would do, but that's something that you'll likely see. And then of course, medical intervention as well. All right, next we have compartment syndrome. Again, this is something that in our field is rare to see, but you need to be able to identify it if somebody is presenting with it, okay? This is a very serious condition where there is increased pressure of the muscular compartments. So you are mostly gonna see this in the lower legs, okay? So I know we haven't gotten to the low legs in anatomy yet, but the muscles of the lower limb are divided into different compartments, okay? And you have certain muscles that sit within those compartments. And the compartments are divided by a more fibrous material, okay? And that material cannot expand. So what happens here is, for whatever reason, if it's overuse, if it's trauma, those muscles are expanding and they have nowhere to go because they don't have the room to expand. They are trapped in this compartment. So then blood vessels, nerves, etc. get compressed by these muscles, okay? So that's basically what is happening in this compartment syndrome, okay? So that fascia is dividing the muscles into compartments in the lower legs, and then that fascia does not expand, even if the muscles are trying to expand, okay? So this can lead to muscle necrosis, rhabdomyolysis, it can lead to infection, it can lead to like a peripheral paralysis, loss of limb, and it can even lead to death. So again, very serious. Some causes of this, big thing that you'll see is a poorly fitted cast. Okay, if a cast is too tight on the lower limb, that can cause this. Okay, it can be caused from trauma, okay, as well as overuse. Okay, you will see it a lot in runners. Okay, so typically the presentation with that is going to be every time I get to, let's say, 2 miles, okay? You're gonna have a very specific mark where they start to exhibit severe symptoms. But then once they stop, all the blood flow reduces, the muscles shrink down, then they're okay. So if it is a repetitive overuse type of compartment syndrome, you're usually, those are the type that you're typically gonna see in physical therapy, okay? Versus, oh, I just got in a car accident and you have this really acute, severe, scary compartment syndrome, okay? But if somebody does have that, then they're gonna have to undergo surgical intervention, okay? Where they go through and actually cut the fascia. So it gives the muscles space to swell. Let's see. Oftentimes when they do the surgery, they leave these wounds open and cover it with a sterile dressing. So they give it that time that's needed in order to heal, in order to reduce in size, and then they would go back and close it 48 to 72 hours afterward. Okay. So one of the resultant things I mentioned was rhabdomyolysis. So this is going to be a rapid breakdown of skeletal muscle tissue. Okay? It is going to result from a large release of enzymes and cell byproducts that go into the bloodstream. As the muscle breakdown occurs, the byproducts of that are going to accumulate, and that can result in acute renal failure. Okay? So when you hear rhabdomyolysis, the first thing your head should go to is renal failure. Okay? So again, this can be caused from several different things. Okay, it could be more mechanical injury, physical, or chemical injury as well. In terms of somebody's symptoms and clinical presentation, they're going to have very severe muscle pain. It could present with skeletal muscle necrosis. They're likely going to go into shock. Okay, that's typically what you're going to see with a renal failure. They could have dysrhythmias of the heart, so it could end up being fatal. And then, like I said, acute renal failure is likely to occur with this as well. For diagnosis, they're going to do blood work. So they're looking for elevated creatine phosphokinase, and then any abnormal renal function as well. Okay, for treatment, a lot of this is correcting electrolyte imbalances. Okay, so you will see this if you do a lot of coverage for endurance events. Okay, so 50Ks, 100Ks, where people are really overworking for a long duration of time. Okay. And then they may require dialysis, especially in the presence of renal failure. All right, a few more until we get a break. All right, sprains, strains. Hopefully we know the differences between these at this point. But what is a sprain versus what is a strain? A sprain is a ligament, okay? So you sprain your ankle. That's going to occur to ligamentous tissue. Okay? So this could be a partial or a complete tear, okay? The most common place that you're gonna see this is in the ankle. And then you have different grades of an ankle sprain, or different grades of a sprain in general, okay? Grade 1, there's going to be just a slight stretch to the ligament, okay? Grade 2, you're gonna have a partial tear of the ligament, and grade 3 will be a complete tear of the ligament. Versus a strain, you're going to strain a muscle, okay? So this is going to be an overstretch or a pull of muscle tissue. Okay. Again, you have 3 grades here, okay? Grade 1, you have damage to less than 5% of muscle fibers, okay? So this is gonna be symptomatic, but it's going to be very mild. Okay? You're not gonna have any big impairments here. Grade 2, you still don't have a complete rupture, but you have more extensive damage than grade 1, okay? So you're gonna have tenderness to the muscle here, there's going to be decreased range of motion, and there's going to be loss of strength. Versus grade 3, you have complete rupture of a muscle. So this is going to be an immediate onset of pain, there's going to be swelling, edema, and the entirety of the muscle has been ruptured. Okay? A lot of these you will see with overuse, as well as eccentric loading of a muscle. Okay? And then last one here we have is tendinitis. Okay? Tendinitis is going to be inflammation of a tendon. Okay? When you use the term tendinitis, you are indicating an actual inflammatory response. Okay? Versus tendinosis. Okay? Tendinosis is going to be the degeneration of a tendon, but there is no active inflammatory process. Okay? So you will hear these terms used interchangeably, but they are not interchangeable.
Will you
Okay?
repeat tendinosis?
Tendinosis is going to be the degeneration of a tendon. Okay, so there's no active inflammatory process occurring with it. Okay, you'll also hear the term tendinopathy. Tendinopathy is going to be the umbrella term. So that could be indicating either a tendinitis or a tendinosis. Okay, so again, this is typically, that's something that is going to occur more insidiously over time, repetitive use, repetitive activities. And then in terms of your treatment, again, a lot of times, if somebody goes to a doctor and they have tendinitis, the first thing they're going to do is tell them to rest. Rest, ice, elevate, compress, etc. They might put them in a boot. All of these things are wrong. Okay? So the best thing that you can do for a tendinitis, a tendinosis, tendinopathy, whatever term you want to use, is loading. Okay? You have to load the tendon in order to correct the problems. Okay? That is how they are going to get better. You want to start with isometrics, and as they're able to do those in a symptom-free manner, progress to eccentrics. But you have to load it. Alright, so next break, I want you guys to partner with somebody different and go through these terms. Okay, make sure you understand the definitions and the differences between your strains, sprains, tendinitis, tendinosis, tendinopathy, and bursitis. Okay, because those are the things that we are going to deal with the most in our field. Okay, and take a break, use the bathroom, as you need to as well. Just the basics of oncology, and then go back to musculoskeletal specific oncology. Okay, so oncology is going to be the study of malignant tumors. Okay, so we're looking at cancer here. So we have the incidence here for males and for females regarding new cases and deaths. So that is listed in order of your most prominent type of cancer to least, and for your top 3 new cases and deaths. Okay, so for our tumors, so we have a neoplasm. That is going to be an abnormal tissue that grows by cellular proliferation more rapidly than normal. Okay, so a neoplasm is a tumor. Okay, these are going to be named by their related body system. Okay, so the root word specifies the cell of origin, okay, and then the suffix indicates whether this is going to be benign or malignant, okay, as well as the type of tissue that is involved. So you have this little tumor classification thing where it shows the root, the suffix, an example of it. So you guys can look at that individually and just understand the general naming system for these types of tumors. Yeah.
On the table, it says that both omas, or all 3 omas are benign, so oma is just tumor, is that right?
Oma is tumor.
And then what makes it malignant versus benign? Is there a reword or a prefix or suffix for that?
Typically carcinoma or sarcoma is gonna be more malignant
Okay,
versus just,
just remember those. Okay, great,
Yeah.
thanks.
okay, and then benign versus malignant tumors here. So benign are going to be non-malignant tumors, okay? These are usually encapsulated, so they can expand or shrink without actually spreading to another body region, okay? So again, you have these differentiated cells, going back to lecture 1, that are going to reproduce more quickly than just your normal cells. Okay? They can damage tissue just by compression of their adjacent structures, and that can look differently depending on where these tumors are located in the body. Okay? So typically a benign tumor is not going to be life-threatening, but it could be dependent on where it is actually present at. Okay? So if it is putting pressure on a very serious part of the body. Versus malignant tumors, these are going to again have undifferentiated cells that are producing very quickly, and they are going to penetrate the surrounding tissue. These more easily break away from basically their host tumor and can spread to other areas of the body. Okay? When that occurs, that is called metastasis. Okay? So again, just basic pathophysiology, these cells proliferate because of the growth, inhibition, and cell-to-cell communication. These things are no longer occurring normally. So as inflammation and growth increase of these tumors, then the organ function, depending on where it is going to reduce. Okay. Overall etiology, this is going to be based on several different things, okay? So again, going back to a lot of what we previously talked about in terms of host defense, those types of things is very important when it comes to this as well. But there are a lot of different genes that are involved in this as well. They can be responsible for the cell growth, replication, and how these things occur. Let's see. So those that cause, the actual genes that cause cancer are called oncogenes. Just to make sure you know that term. So these changes in the actual cell DNA are a base cause of this malignancy. Okay. Viruses are also capable of producing tumors as well. Okay. In addition to this, you also have chromosomal abnormalities. This can be associated with cancer as well. Gene mutation, when they mutate, they can end up functioning differently, and that can play a part in the formation of tumors. Let's see. And then, like we already said, if depending on the host defenses, if your immune response fails, that cellular growth can also become uncontrolled as well. Okay? And then, of course, you're going to have a hereditary component to it as well, especially types of cancers or tumors like breast, colon, ovaries, lung. A lot of those are going to have a hereditary component. So carcinogenesis, this is the actual process where the normal cells transform into cancer cells. So you can have a lot of different risk factors that can cause this. And then, like we said, you can also have this triggered by a virus. Okay, so they're called oncogenetic viruses. Okay, so for example, you have HPV. Okay, you know, we all get checked for HPV. That can trigger cervical cancer. Okay, so that would be an example of an oncogenic virus. There are 3 stages of carcinogenesis. Okay, so one is the initiating factors. So this causes the very first irreversible cell DNA changes. Okay, could be genetic changes. It could be exposure to environmental factors. Number 2 is going to be exposure to promoters. So that could be hormones, that could be chemicals, is going to cause your later stage DNA changes. Okay, this is going to lead to the tumor development. And then number 3 is going to be continued exposure and DNA changes. Okay, so that's the part that is going to result more in the malignant tumors. Okay, we also have angiogenesis. So this is going to be an enlargement of the tumor and deprivation of its inner cells of blood and nutrients. Okay, so that is going to lead to necrosis, inflammation, and localized infection. Okay, so certain tumor cells are going to stimulate this angiogenesis, which again is going to promote more your tumor development. Neoplasms in situ. So this is going to be your neoplasms that exist in that pre-invasive stage, okay? So pre-invasive stage of cancer, that can occur for a short period of time, it can occur for a long period of time, okay? So at this stage, this is where you can start getting that early diagnosis. Okay, so this is really important. This is why your screening tests are important. Okay? This is when you're trying to identify these things and would have a better prognosis if you're able to go through that early identification. Okay? In terms of the actual spread of these tumors, they can spread in several different ways. Okay? They can produce secondary tumors that are going to be identical to the primary tumor. And a lot of these things are going to metastasize before that primary tumor is even identified or known about. Okay? So that has to be diagnosed before treatment can begin, because you have to know what you're dealing with. So these are going to be your 3 main methods of the spread of malignancy. Okay? So number 1 you have is called invasion. So here, there's going to be a more localized spread of the tumor cells. So it's just going to go to, you know, their neighboring tissue, adjacent tissue. And it's going to go in and destroy the cells there. Number 2 is metastasis. So this is the spread through either the lymph or the blood of the body. So it's going to go to more distant sites. So it's not going to be as localized, it's not going to be as adjacent. So with this, when you hear people who've had their lymph nodes removed, okay, this is why, okay? A lot of times the lymph nodes are going to be the first area that cancer metastasizes to. So if you can take it out from there, then you can help to prevent that spread in the lymph. Okay, and then number 3 is called seeding. So this is where the cancer spreads through the body fluids or the membranes. Where the tumor cell will actually break off and then travel with the fluid and tissue movement. Okay, we also have the actual staging for cancer on this slide. Okay, this is important because it is going to give you a lot of information about the severity of their condition. Okay, so stage 0 is going to be precancerous. Stage 1, it is confined to its place of origin. Stage 2, it has invaded, so it's more localized. It's invaded the nearby organs or tissue. Stage 3, it has spread to the lymph nodes. Okay, and then stage 4 is going to be metastasized to distant locations. Okay, we have 9 big warning signs. I must have combined 2 of them because we only have 8 old ones here. But we have 9 big warning signs, okay? It is very important for you guys as healthcare providers to know these like the back of your hand, okay? So any type of unusual bleeding or discharge, as well as anemia or low hemoglobin, changes in bowel or bladder function, changes in appearance of moles or warts, sores that will not heal, unexplained weight loss, a solid painless lump, persistent fatigue, or persistent cough and hoarseness. Okay, these are your early warning signs of cancer. And especially when you guys spend so much time with your patients, sometimes you are the first person to identify that something is wrong. Okay, so every evaluation that I do, I know you guys are not gonna do evaluations, but every evaluation, I am always gonna ask about changes in bowel or bladder function, unexplained weight loss. Those things, as well as night sweats. I know that's not on here, but that is another very important sign, okay? Or night pain as well. Night pain that they cannot change, okay? It's keeping them up at night, doesn't matter what position they lie in, it doesn't go away. You can't make it change from a musculoskeletal standpoint, okay? So those are some of the big warning signs that you always want to keep in the back of your mind, just in case things are not adding up when you're treating a patient for a musculoskeletal condition. Okay?
I didn't know it was painless lumps. I thought it was just the opposite, so it's pain, if a lump is painless.
That's gonna be one of your warning signs.
Okay, was that breast as well?
Yes.
Okay.
Not to say they couldn't have pain in them, but that's gonna be more an indicator.
So the nerves, I guess the nerve doesn't run through that lump.
It's gonna be dependent on
Yeah.
so many different factors. Okay. Systemic effects of malignancy, okay? So like we already said, weight loss, that's gonna be a big one. Pain, anemia, cachexia. Cachexia is severe tissue wasting, okay? Severe tissue wasting. Infections, bleeding, etc. And then localized, so you could have pain, but it's gonna be more localized pain versus more just full body pain. Tissue necrosis, ulcerations. So I know this doesn't give, a really good picture of anything. It is all very general, very vague, but that's also how these patients are likely going to present as well. And then kind of like Jacqueline was just saying, in your early stages, they're likely not going to have symptoms. They're likely going to be pain-free. They might have lumps that are not painful, and then those things will change over time. Okay? Anemia. This commonly will result from anorexia and decreased food intake. Okay? There could also be bone marrow depression, and there could be chronic bleeding as well. Okay, so you're gonna get iron loss overall, okay? With that, that means that the oxygen that is available within your cells has decreased, okay? That's going to lead to a lot of fatigue, poor tissue regeneration, which is why you're gonna get the sores, a reduction in your host resistance, as well as increased susceptibility to infection. Okay, paraneoplastic syndromes. This is going to be related more to the lungs, so bronchogenetic carcinoma in the lungs. Okay, so here it could affect blood clotting, it could affect neurogenic factors. This could cause Cushing syndrome, which we'll talk about at a later time. And if this is present, it can really complicate things for the patient. Okay. With the increase in tissue necrosis, with the increase in infections and ulcerations, you're more likely to develop infections surrounding the tumor. Okay? This goes back to the opportunistic infections that we talked about in the first couple weeks of class. Okay? So overall, as a host, your resistance is going to be much lower. You're going to be much more susceptible to infections because of everything going on with the tumor, with the cancer, all of these other factors. And you are going to be much more susceptible to additional infections with that. Okay, so here's a big list of risk factors for cancer. Okay, one of the most significant is first listed is advanced age. Okay, there is a ton of other factors that are going to play into this, okay? You have both modifiable and non-modifiable factors, okay? So non-modifiable, your gender, ethnicity, family history, you can't do anything about those things, right? But then your modifiable, smoking, stress, occupation, all of those types of things as well, okay? More than 1/3 of cancer deaths are actually related to modifiable risk factors, okay? So that's actually a huge number. So educating your patients is important, understanding this for yourself and making changes as needed as well. Okay, and then, so those are just more your general risk factors. This slide is more specific factors for more specific types of cancers, okay? So we're not gonna read through all of these, but just as an example, we know that genetic factors are going to lead more toward breast cancer, okay? So that's kind of how this reads. In terms of diagnostic testing, like I said earlier, you have a much better prognosis with early identification. So making sure that you're getting your screening tests done at the ages that you're supposed to, making sure you educate your patients on doing those things is very important, okay? When you do these things early, you have a much better prognosis, more likely to save somebody's life, okay? Let's see. In terms of actual diagnosis, you can see listed bullet point number 2, the only 100% accurate test for malignant tumors is actual examination of the tumor cells. Okay, so you have to do a biopsy, have to actually look at those cells to understand what is happening. Okay, there are blood tests. You can look at the hemoglobin, erythrocytes, just looking at general signs of cancer, but again, it's not going to be very specific. Also bone marrow exams, that's very common for certain types of cancers. Let's see, those are really gonna be your big things, but you have several different tests listed that might be seen or used here. For chemo, you have different types of chemo dependent on the type of cancer that is present, okay? Because the different cancer cells are going to respond differently to drugs. Okay, so this is something that it could be used in isolation. It could also be used in conjunction with surgery where they actually remove the tumor, or with radiation as well. Okay, most commonly, there's going to be a removal of the tumor, and then within the following 6 weeks, the individual would be in chemo. An adverse side effect of chemo is going to be bone marrow depression. Okay, this is the most important thing to consider. They might require fusions because of low blood counts. Sometimes they have to stop the chemo in order to allow the blood marrow to recover for a short period of time first. But usually they're going to do blood tests before each treatment just to understand exactly what is going on. Let's see. A lot of these agents that they use in chemo are going to stimulate the vomiting center in the brain, so you hear a lot of people getting sick from this. And then a lot of people are going to lose their hair as they go through this as well. So just things to be mindful about if you're treating somebody in this population. All right, radiation, again, this could be used alone or in combination with these other therapies. It often causes DNA alterations, where it can go in and kill the cancer cells, but keep intact the normal cells. Okay? It can also damage the blood vessels that actually carry the blood supply to the tumor cells. So this is, because of all that, this is going to be most effective on the actual cells that are going through DNA mitosis or DNA synthesis. Okay? So again, this is something, it could either be used before a tumor removal, okay? Or again, afterward, usually about 6 weeks after is when they would start this. Similar to the chemo, you can still get bone marrow depression through this as well. Okay, we also, of course, have palliative treatments, okay? This is more about keeping a patient comfortable, okay? For this, you have several different types. You have physical, emotional, practical, and spiritual. So physical, thinking, more the medication side of things, physical therapy, breathing, your radiation, surgery, okay? Emotional being more the actual support from others, so counseling, support groups, family meetings, things like that. Practical is more like, think like legal counseling, financial, insurance, wills, those types of things. Advanced directives, that's very important. And then spiritual, so religious or spiritual counseling. Okay, there's also adjuvant therapy. This is more prophylactic, especially when there is a cancer present that they know is easy to metastasize, okay? So we also have immunotherapy, so helping to stimulate the immune system, again, more prophylactically, in order to help fight the cancer or prevent it from metastasizing as best as they can. Nutrition. Like we were saying earlier, a lot of these individuals are going to be, it's going to result in malnutrition, okay? There's gonna be anorexia, vomiting, pain with eating, malabsorption, etc. So making sure that you educate on the importance of diet and helping to find things that they are capable and or willing to eat, okay? So, yeah.
There's more of, so like how nutrition, could like, can that like, so like if like two people are like married or something, if they both like, are eating the same thing, going through, can that cause like the same cancer in both of them? Cause my aunt and my uncle got sick and with a certain cancer. He was like super healthy, and just all of a sudden out of nowhere happened. And then he went through all that stuff, and then she got sick with the exact same cancer out of
What kind
nowhere.
of cancer?
I don't know, I think it was something in the throat.
It's typically, there's going to be a wide variety of reasons that somebody develops cancer, and it's not just going to be one isolated thing that resulted in it. So there's going to be a hereditary component, and then there's going to be those modifiable risk factors, whether it's, smoking or eating or whatever it is that all play into it. But more, it's not likely just gonna be, oh, we were eating this one type of food and that's going to result in cancer, in the same type of cancer in two people.
That's where I was not really strictly the same time. That just made me. But
There could be some other component where they were both exposed to it if they also already had a genetic predisposition to it. All right, in terms of prognosis, okay, these are just your textbook definitions, okay? So cured, we put in quotation marks because we know what that means. But technically, that would be 5 years without recurrence, okay, after the diagnosis and treatment. Remission just means having no active clinical signs of a disease. And then just know your prognosis is going to differ very widely dependent on the individual types of cancers and individual factors. Okay, so that will be more case-by-case basis. Like I already said today, screening is very important, okay? Self-exams, getting your regular screening test done from your physicians. Early detection can make a really big difference when it comes to these pathologies. So making sure that you guys are active participants in your own healthcare and making sure you educate your patients on doing that for themselves as well. Okay? All right, we're getting there, guys. Like, what, 12, 13 more slides? Musculoskeletal neoplasm. So now, cancer in specific to the musculoskeletal system, okay? This is chapter 10. So again, this could be benign, it could be malignant, same as before. We're just looking at the actual musculoskeletal. So, starting first just with benign bone tumors. So, when this is benign, these tumors are going to have very clear edges within the bone. Okay, the edges of the tumor sit within the bone, they are clear, and they might be surrounded by a slight bit of sclerotic bone. Okay, your most common bone tumors, let's see, they're all listed right here. Okay, chondroma, osteoma, osteochondroma, and giant cell tumor. Okay, a chondroma is going to be hyaline cartilage. It's very common in the hands and in the feet. An osteoid osteoma, or an osteoma, same thing, same terms. This is going to be small and bony, okay? It is going to occur in the long or the flat bones, like specifically in the skull. You'll see those there. Okay? In osteochondroma, this is going to be the most common benign type of tumor within your musculoskeletal system. Okay? This usually occurs in adolescence when the skeleton is still growing, and it will start in the growth plates. And then an osteoclastoma or a giant cell tumor, this is going to be much more uncommon. So an uncommon type of tumor, and that can metastasize through the bloodstream. Oh, I got a little ahead of myself. Osteoid osteoma, okay? So this again is going to be a benign vascular type tumor. It is pretty rare. And like I said, this is going to occur more at the ends of the growth plates. Okay? These are not progressive, and they're typically very small. Okay? Usually in terms of clinical presentation, they are going to have kind of a very dull ache, okay, in the area wherever that tumor is. Okay? Like I said earlier, pain is going to be most intense at night. So night pain where they can't change positions to make it go away. Okay? Usually this is going to have to be surgically removed. Okay? An osteoblastoma is a reactive benign bone tumor. Okay, so these are going to be a little bit larger than your osteoid osteomas, but they're going to, look similar in terms of their actual composition. So again, this is going to be younger males, 10 to 20 years old. The pain is going to be less severe than in an osteoid osteoma. Okay, they still may have a slight tenderness over the involved site, but it won't be quite as bad. So again, typically, they're going to have to go in and remove this surgically. Okay? They can still occur even after surgical removal. Okay? And then they could also transform into an osteosarcoma, which would be malignant. So an actual primary musculoskeletal neoplasm is not common, okay? So typically, if you have a tumor in the musculoskeletal system, it is not, that has metastasized, it is not usually the primary tumor, okay? Meaning that if somebody has it in the musculoskeletal system, it has metastasized from another area of the body. So it is usually the location of a metastasis, okay, versus the primary tumor. Okay. The most common tumor for the bone marrow is a myeloma. Okay. If it is a primary tumor, this is going to look very different than your benign tumors. Okay. That means that it is not going to be as well defined. Okay, so it does not have a defined shape. The edges are going to be less clear. The borders will not be sharp. And then the edges will extend beyond the edge of the bone that it is on. Okay? So here is a list of your different types of primary bone cancer. Okay, this is also directly from your book, so you guys can read through those, but these are your types of malignant, primary bone cancer. So first, we have an osteosarcoma. So again, this is going to be your most common type of primary malignant bone tumors. Okay, so this is most commonly going to affect the long bones. Again, more at the growth plates, your epiphyseal growth areas. So think more the distal femur, tibia, fibula, that's where you're most likely gonna see these. Okay, so again, very deep local pain with these. Night pain, it's gonna wake them up at night, it's gonna keep them up, they're not gonna be able to roll over and go back to sleep. Okay. They might have swelling, joint range of motion will likely be limited. Okay, usually an x-ray will be enough to see the tumor. Okay, if not, you could also see it through MRI or CT scan. This type of tumor typically will metastasize to the lungs within the first 2 years. Okay, so again, that early identification is important. And it's pretty scary, especially since you're dealing with the younger population here. Okay. Treatment here, of course, it's gonna be surgery. They're gonna have to go in, remove the tumor, and then chemotherapy as well. Dependent on the severity of it, the size of it, what it's already done, it might even lead to an amputation. Okay, so this is a potential surgery that you guys might see, okay? So again, if an amputation is required, dependent on the area of the tumor, these are some options for surgery. This one up here is really severe, but it is very functional, okay? So if you can see in the picture, these will typically occur when the osteosarcoma has occurred in the femur, okay? So they actually remove the femur and they take the lower leg and turn it around and reattach it, okay? So they keep the foot intact because now the foot, your plantar flexion and dorsiflexion, can function as knee extension and knee flexion. So if you put a prosthetic on the bottom of the foot, they could walk totally normal using their own mechanics. Really wild, but it's really cool that somebody even came up with that. So, does that make sense? I'll see if I can pull the video up maybe before we leave so you can see what it looks like. All right, we also have Ewing sarcoma. Okay, this is also very highly malignant. It metastasizes very quickly all over the body. Okay, this develops from the bone marrow. It is the 4th most common malignant tumor. Okay. Usually this is going to appear in the distal femur first. Again, they're going to have more localized pain and then maybe more systemic symptoms as it progresses. Again, you could use CT, MRI here in bone scans to assess the tumor and look at that size. And then this is going to be really intense treatment. So chemo, radiation, immunotherapy. Again, you might end up with an amputation here. But it's something, if there is early identification, it is highly curable if it has not yet metastasized. So that's, again, the importance of the early identification. Okay, so here is a comparison for chondrosarcoma and fibrosarcoma. So chondrosarcoma, this is going to be more a malignancy of the cartilaginous cells. Again, this is going to occur more in the long bones. You may also see it in the pelvic girdle and the scapula as well. It will be more slow growing. It is very resistant to radiation and chemo. And again, this can transform into a very highly malignant form. This is more common in males. especially as they start to age a little bit more middle, later age, or later life. These will also be asymptomatic for a longer duration. Okay, so it can be very hard to identify early on. Okay. A fibrosarcoma, it's also gonna be a malignant tumor that is involved more in the fibrous connective tissue. Okay, I'm not gonna go into all the details, your book does dive a little bit further deeper in, but it is going to involve more of the deep soft tissue, again, more common in middle-aged to older adults. Again, you might require surgical resection, chemo, radiation. Multiple myeloma, this is going to be a malignant neoplasm of the bone marrow. Okay, so this is a primary bone cancer. It will arise from the B lymphocytes and plasma cells in the bone marrow. This will cause more a weakening of the actual bones. So you might see more fracture with this, a lot of pain. It does have an unknown cause. In terms of diagnosis, again, X-ray, MRI, CT, a bone marrow biopsy is gonna be really important for this population. And then potential for blood and urine testing as well. This does have a poor prognosis, okay? So you're looking at more palliative type care for this type of cancer. Usually individuals will die within about 1 to 3 years. All right, metastatic bone tumors. So again, like we said, this is going to be once it's spread to distant sites and then grows to different sites. So this is going to be a progressive process where you have those initial cells from the primary tumor, they invade nearby tumors or invade nearby sites, and then go into either the cells or the lymph and invade distal sites as well. Okay, this can occur with any type of cancer at all. You are most commonly going to see it with prostate cancer, breast cancer, kidney, and lung cancers. Okay. Again, once you get to this phase, a bone scan is going to be the best type of assessment because you can see everything happening in the entire body. Okay? More locally, you could use X-ray, CT, or MRI. Okay, so then here is just a breakdown of some of the different soft tissue tumors that you'll see and the percentages that are associated with them. Okay. And then in terms of treatments, okay, everything is going to be individualized. It's going to depend on the different type of cancer that's present, the individual themselves, what they're able to tolerate. So you have all of these different things that have to be taken into consideration with it. Okay. All right, and that is it. You guys made it. Let me see if I can find a video real quick of a rotation plasma.